My name is Dr. Jaypal, and today topic is disorder of sex development. And first of all, we go forward through the introduction. And DSD are defined as a congenital condition which is the development of the chromosome gonadal or anatomical sex is atypical, which is estimated in 14500 births. And DSD are affected individual physically and psychologically, socially, and well-being. Understanding DSD is a crucial effective for the medical management and providing the support effective individually and their families. And then, before we going forward, the DSD first we know about the normal sexual development, and the normal sexual differentiations begin during the fetal development and involve the complex process influenced by the genetic, hormonal, and environmental factors. Generally determining happen at the conception of the XS karyotype predicting the female and the XY karyotype being male development. This is the picture showing there is a mesonephric duct and the Wolfram duct is present, and there is a female. There is a mesonephric duct is going forward and form the ovaries, form the fallopian tube, uterus, and upper part of the vagina. In the male, there is a mesonephric duct is regressed by the help of the MH, which is secreted by the Sertoli cell. And there is a Wolfram duct progress which form there is epidermis, vas difference, and seminal vesicle. And this is the only normal formation of the how testes and ovaries are formed and how internal genitalia is formed. All of the slide, all of this presentation is totally based on this one of the important slide. And there is a we see there is a most determining sex determining gene is the SRY gene. If the SRY gene is present, this goes forward the testis formation, and the testis formation has the two cells. There is a Sertoli cell and one is the Leydig cell. And Sertoli cell, which is secreted the AMH anti-Mullerian hormone, which is a regress of the Mullerian duct regression. And there is another testosterone secreted by the Leydig cell, which is act on the internal genitalia hub by the help of Wolfram duct, which is formed the epididymis, vas deferens, and seminal vesicle. But testosterone does not act on the external genitalia hub, but it's a more potent form by hydrotestosterone, which is convert from testosterone to dihydrotestosterone by the help of the 5-alpha reductase, which is formed by the external genitalia. There is a penis and a scrotum. And there is another, the SRY gene is the negative, means there is no AMH hormone. There's no AMH hormone. There is then the Mullerian duct is progress and form the fallopian uterus and upper vagina. And there is no testosterone means estrogen is progress, which estrogen is progress that form the lower end of the vagina, clitoris, and labia. And here is there is no testosterone means that the Wolfram duct is also regress in the female. These are normal sexual differentiation with the intrauterine timing. And there is a 7 to 9 weeks or before the undifferentiated gonad is present, and after the after 9 weeks, there is 8 to 11 weeks is progress toward the internal genitalia. Internal genitalia means Wolfram and Mullerian duct as already described previously. Wolfram is formed toward the male and Mullerian formed towards the female. And then the external genitalia is 8 to 20 weeks, and only internal as well as external genitalia is formed before the 20 weeks of the gestational life. Now, DST are caused by the abnormal gonadal differentiation and development or function. The karyotype based help in understanding the etiology of DSD and planning workup and management. And there is 3 types of DSD we describe here: 46XX DSD and 46XY DSD, and another is a sex chromosome DSD. We describe one by one shortly. And there is a XX DLC in which there is the commonest form of the DSD, and we see there is an androgen excesses by the by health defect in the baby or in the mother. What are the causes of the baby is there a congenital adrenal hyperplasia, in which there is a 21 hydroxylase deficiency and 11 beta hydroxylase or 3 beta HCD. And another is aromatase deficiency, and mother there is mostly there is medication by taking the androgen in their pregnancy and are anticonvulsant, which likely phenothion and other malignancy. And this is the normal development synthesis of the mineralocorticoid, glucocorticoid, and sex steroid. All of the congenital adrenal hyperplasia is only depend upon this slide. If you know about this slide, then you will easily understand by further. And there is we are focusing on the only 3 to 4 enzymes, but there is each and every step is pathway, and this pathway is very important. And we initially moving for the 17 alpha hydroxylase. If there is a deficiency is present in the 17 alpha hydroxylase patient, means this cycle is does not go forward, and means that glucocorticoid is also deficiency and their sex steroid also deficiency, and this cycle is going forward like in vertically go forward the mineralocorticoid and aldosterone. Aldosterone is forming excess in form. There is patient present with salt retaining hypertension and the low cortisol and low sex steroid hormone. If there you go forward, if there is a 21 hydroxylase deficiency is present, means these are the mineralocorticoid and glucocorticoid does not form. This cycle does not going forward, but the cycle goes forward like this, and we exercise the estrogen or testosterone formation. And patient is mostly our present with there is the a deficiency of the aldosterone and glucocorticoid and excessive of the testosterone. If there is patient present with the deficiency of mineralocorticoid, means that a patient will be present with there is a salt wasting adrenal crisis, which is present dehydration and vomiting, just a life-threatening condition. And another we see there is a 11 beta hydroxylase enzyme. And this, if the deficiency of the 11 beta hydroxylase deficiency is present, this means that we are present with the same like condition, but the deoxycortisol is here. Deoxycorticosterone is which act as a minimal precursor of the aldosterone. That's why patient does not present 11 beta hydroxylase with the adrenal crisis and salt wasting condition. May be present with the rarely found 11 beta hydroxylase patient present with adrenal crisis, but mostly does not present with this. And there is another enzyme. There is a 3 beta HCD and 3 hydroxysteroid dehydrogenase enzyme. If a deficiency of this enzyme means 3 cycle known even sex steroid, glucocorticoid, mineralocorticoid, third of the 3 of the enzyme are not formed. Then the testosterone is also low, and cortisol is also low, and aldosterone is also low. As you already know, cortisol is sending signal to the pituitary gland, and pituitary gland is secreting the ACTH. And patient is also present with there is a low aldosterone, low cortisol, and low testosterone level, and high ACTH level. And these are the all characteristics of the congenital adrenal hyperplasia. As we already discussed, 21 hydroxylase patients is mostly ambiguous, present is likely in a female, and there is adrenal crisis are most likely present with it's a life-threatening early to diagnosis and best to manage it. The first 2 weeks of the life is the 21 hydroxylase is very important. And the low glucocorticoid and low aldosterone levels and androgen level is also high because of the all cycle are shift toward the sex steroid formation. And sodium concentration low, and opposite there is a potassium concentration is all elevated, and there is a metabolite elevated in the 21 hydroxylate, which is this 17 alpha hydroprogesterone. Mostly 21 hydroxylase patient present with the 17 alpha hydroprogesterone level is raised. And then we see the 11 beta hydroxylase deficiency. There's the ambiguity mostly present in the female, and the adrenal crisis is mostly rare forming because of deoxycortisone is present, which act as a mineralocorticoid aldosterone level. And the glucocorticoid level low and mineralocorticoid is high, and the androgen production is also increases because of this. All cycle are shifted towards sex steroid. And there's 17 alpha hydroxylase deficiency. is mostly is rarely these are the both enzymes are present, but there is also maybe in the ambiguous genitalia mostly is the males, and there is adrenochromatosis not present, and mostly glucocorticoid and low and mineralocorticoid is high. And sodium concentration is if the mineralocorticoid is high, means sodium concentration is also increased in patient present with the salt attending hypertension. And these are the element deoxycortisol and cortisone is level is both of the increase in this condition, and the 3 beta HCD is, as you all know, all of the hormones are decreasing level, even mineralocorticoid, glucocorticoid and androgen mostly, and patient is present with the elevated level of the DHEA, which is present in this dihydroepidurontenone sulfate. This is also elevated in the 3 beta HCD. In the mostly CAH patient present with the apparent hypospadias and bilaterally non-palpable gonad should be investigated for CAH before the discharging because of the one of the fearful 17 alpha hydroxylase deficiency enzyme, which is mostly present life-threatening condition. That's why we diagnose this patient as early as possible. And there is aromatase deficiency. Aromatase mostly causing as the peripheral conversion of the testosterone to estrogen. If there is a deficiency of this enzyme, patient present with the 46XXDSD, but there is a aromatase deficiency, does not converting the testosterone to estrogen. There is a patient present with the accumulation of androgen and muscularization of the external genitalia. And there is another, the 46XX testicular DSD, in which there is a translocation of the genetic material from secondary determining region of the Y chromosome into the X chromosome. And there is an external genitalia, usually unambiguously male, but is also undescended testes, hypospadiasis, and infertile. Patient have the XX karyotype is XS, but there is only a defect in the chromosomes of the SRY gene. That's why the patient is present with the undescended testes and hypospadias and infertile. And mostly of the treatment, there is androgen replacement. Another classification of another form of the 46XY-DSD, in which there is a wide range of disorder, either by the testicular development or androgen production and action. And disorder of the gonadal development have variable presentation with or without gonadal palpable and Mullerian structure. And stereogenital defect is have palpable gonad without Mullerian structure, reflecting the normal AMH secretion. If there is a patient present with the without the Mullerian structure, means there is a testis is present which Sartori cell which causing secretion of the AMH hormone. There's a 46XY-DS gene we describe one by one, in which there is a gonadal development defect either by the complete or partial gonadal dysgenesis or the gonadal regression. Another, there's a gonadal function. If the gonad is present, but the synthesis and function of the defect and their activity of the gonadal or activity of the androgens. And then another causes the LH receptor defect or MH defect. These are some genes are involvement with the XYDSD, in which there is a WT1 gene is mostly involved with the renal involvement, and there's NRFA1. There is also present with the cell wasting, and SRY gene mostly here we described as early, the most commonly present with patient. And there is another two genes, DX and XOX. And there is now there is disorder of the testicular development. These disorder are defect in the gene is involved in the development of the bipotential gonad, testes, and ovaries. These are the different genes WT1, NFRN, XRX, XRX. Please see in slide is present. And there's a testicular regression. If the absence of the one or both testes and corresponding reduction or absence of the testicular function. External genitalia are ranging from the typically phenotype with micropenis or male or with the typically female genotype. Because of the no testes present, no testes, no Sartori cell, and no testosterone. It is a complete, if the complete gonadal dysgenesis is also called as a severe syndrome, in which there is severely dysgenetic and non-functioning testes. Karyotype is XY, but there is a testes is present, but they are not non-functioning testes. Typically, patient present with the female appearance, present at the puberty with hypergonadotropic and primary amenorrhea. Most of the patient is born with the female appearance, but when he reach the puberty level, patient does not conceive a child or primary amenorrhea present. Then investigation done, and then we see there is a 46X5 karyotype is present, but patient typically born with the female. Then we mostly go for the gonadectomy because of the patient have the Y chromosome, which is always carry the risk for the risk of malignancy. And we also go for the hormone replacement of this X factor 6. If the partial gonadal dysgenesis is a varying from degree of the impaired testicular function, either are exogenous are usually ambiguous, or rudimentary, or completely formed uterine structure. Is it only depend upon this if the how much the MH is present and how much the test is present. That's why patient is present individually, and we go for the treatment is also according to patient vary. If their hormone replacement or gonadectomy or kidobexy or genetoplasty. And there is a 3 beta hydroxydehydrogenase deficiency, as already described in previous slide. There are 3 beta dehydrogenase deficiency patient present with the all low testosterone, low corticoid, and low glucocorticoid. All of the hormones are decreasing. Incomplete or absent muscularization of the external genitalia, and ambiguity are typically patient female appearance and sol vesting, decreased cortisol and aldosterone. And mostly we go glucocorticoid and monoglucocorticoid replacement is given. And another is a file for reductase deficiency. If there is then this is the testosterone is present, but there is not converting in the dihydrotestosterone. Dihydrotestosterone is mostly involving the external genitalia. Internal genitalia patient is normal, but there is one of the defect of the 5-alpha reductase which not convert into dihydrotestosterone, and that's why patient has the external genitalia has ambiguously present. The synthesis of the testosterone normally and internal genitalia is normal, and virilization occur at the puberty at the response of the exposure of the high level of testosterone. At the puberty time, the high level of testosterone is secreted, then virilization can occur, and patient mostly present with the hypospadias, small phallus and short vagina. Mostly we go for the reconstructive surgery. And there is an androgen insensitivity syndrome. There is an X-linked disorder, recessive disorder affecting the androgen receptor, characterized by the high dihydrotestosterone and testosterone level. And there is the androgen testosterone is also present, but there is an effect of defect in the action of the androgen level. Complete IS is there is a female appearance with the short blind vagina and no uterus. Testes is present in the abdomen or inguinal. And diagnosed mostly female patient, if present with the inguinal hernia. And external type looking like a female, and but investigation is going forward. Say the primary amenorrhea, and then patient we diagnose the complete AS, and gonadal biopsy is recommended due to the increased risk of testicular malignancy from 2 to 10%. If the gonadal biopsy is negative, then no need of the gonadectomy, which because of the low risk for the conversion of into malignancy. These are the slides on comparison between the 5-alpha reductase and androgen insensitivity syndrome. In 5-alpha reductase, as you already know, there is a defect in the dihydrotestosterone conversion, and complete AS is there. Testosterone is also present, dihydrotestosterone is also present, but there are action defect in the actions. And then there is a testosterone dihydrotestosterone level low, and here the complete AS measure the testosterone and dihydrotestosterone level is high. Mostly puberty as the virilization occur in 5-alpha reductase by the surge of the high testosterone level. And there is not virilization occur, the feminization occur. And gender of having mostly we go forward, there are more likely there are male, and here the more likely going toward the females. because of the patient have the Y chromosomes, and also there is risk of the malignancy. That's why maybe need a gonadectomy. That's why we're going forward the female appearance. And then malignant structure of both of these, there is a absent because of testes is present, which causing secreting the AMH. And management mostly we are the hydrotestosterone, or there is a gonadectomy or estrogen replacement. And there is another comparison between the androgen insecurity syndrome between the gonadal dysgenesis. These are the X-linked recessive and mutation, and there is a mutation in the SRY gene. And the karyotype both present in the SRY female and female appearance as external genitalia. And mostly there is androgen sensitivity, the melanin restriction is absent. But there is a XY gonadal gene is there, melanin restriction is present. Have the Y chromosome, but there is a no testicular. That's why there is a no AMH in patient present with the melanin restriction. And mostly there is a breast is also developed in the adrenal sensitivity because of the testosterone converting the estrogen by the aromatase enzyme. And there is a here the gonadal mostly absent. And there is also the short blind vagina, androgen sensitivity, and gonadal testes are present testosterone high level. And comparison with the gonadal dysgenesis is opposite. And there is a defect if the patient have the testes also present and secreting the AMH, but they're not much amount. If there's inefficient AMH action, decreased action or production AMH result in the persistent melanin restriction syndrome. Patient have a XY karyotyping, and also there is AMH is not formation, means the internal genitalia is like a male, but their external genitalia as phenotype is like normally by the help of the hydrotestosterone. Mostly patients present with the undescended testes and the inguinal hernia. Another types of the sex chromosome DSC is the ovotesticular DSC, in which the karyotype is the 46XX 70%, and the mostly mosaic form is also another 30% may be there. And the ovotesticular, there is a one gonad containing the both tissue, testicular and ovarian tissue. But the ovarian tissue is mostly normal, and testicular tissue is mostly dysgenetic. Another term is a mixed gonad. Mixed gonad means there is a patient, one side is the testes present, another side there is a ovarian tissue is present. This is a difference between the ovotesticular and mixed gonadogenesis. It may be present with the unilateral or bilaterally. And there is a function of the testicular tissue determined by the measuring of the SCG stimulated testosterone level. Here is the picture is shown. And then there is a patient is the extra genitalia show the clitorophallic structure with the single opening and non-palpable gonad. And another there is a laparoscopic view of the this ovotesticular, and there one is one means so there is a testicular tissues, and second is so the ovarian tissue. And mostly of the testicular tissue is a dysgenetic, and the ovarian tissue is a normal. And then there is X chromosome DSC is the Turner syndrome or Klinefelter syndrome. There in which karyotyping is different 45X or mosaic type is present, and mostly patient external genitalia are typically female appearance, but the ovaries are dysgenetic or gonad. And patient present with the short stature, renal or cardiac abnormality, in which there is coarctation of aorta. And the Y chromosomes also here. That's why the patient mostly need the gonadal malignancy. That's why we need the gonadectomy because of the high risk of the conversion of the gonadal malignancy. And the Klinefelter syndrome is a 46XXY karyotyping, and external genitalia typically male, and testes are the small and soft. The patient present the mostly tall, gynecomastia, infertile, hypospadias, increase FSH or LH level, and decrease testosterone. Mostly hormone replacement and replacement therapy is needed. When you suspect there is the DSD or not, if the patient is present with atypical development and the patient have the bilaterally cryptocortisone descended testes or proximally hypospadias and either pinoscrotal, scrotal or perineal hypospadias. If the patient have the unilateral undescended testes with the hypospadias, you also suspect there is a DSD. If there is cleidocromagaly in which there is greater than 1 centimeter of the clitoris and with or without inguinal hernia and palpable gonad. In older patient with amenorrhea and inguinal swelling, older patient likely the androgen insecurity syndrome, mostly patient present at the puberty time, and disorder with the prenatal karyotyping. And how to approach the DSG in the mostly go forward starting with the history and then physical examination and karyotyping screening for CH for androgen and precursor for gonadal response and molecular genetic analysis for SRY gene and gonadotropin levels, pelvic and abdominal ultrasound for pelvic MRI and CT scan, and also last not least endoscopic examination of the genitourinary tract. Here the slide is it shows there is how to go forward forward step by step part approaching the DSD. If the patient we have present with the ambiguous genitalia and did the karyotyping and karyotyping showed there is a 46XY. 46XY is then we see the malignant structure is present or not by the help of the abdominal ultrasound or digital rectal examination. If the patient have the malignant structure is present and patient have the 46XY chromosomes, means there is a XY chromosome and malignant structure is both not normally not present in same patient because of the testes present. If the normally functioning, that's causing the Sartori cell and secretion of the AMH and regression of the malignant structure. If there are 46XY and malignant structure is also both are, then means the defect may be probably gonadal dysgenesis defects or excessive gonadal function, and we go forward the for hormonal level in which there are LH, FS, or testosterone or AMH level. If patient is a 46XY chromosome but no malignant structure is present, normally patient present with normally there is no malignant structure and XY chromosomes, but the patient have the ambiguous genitalia, means may have some defect is there. When we go forward, we see there is the androgen synthesis or receptor action problem, the receptor action or the synthesis action. And then we go forward for the one by one, the LH, FSH, and testosterone level and genetic analysis. If the patient have the karyotyping is 46XY present, there we saw there the malignant structure are present or not. Mostly 46XS malignant structure is present. If there is a no malignant structure present, then probably is the testicular DSD. Have the 46XX DSD, but there is a testicular is present which causing the regression of the malignant structure and assess the gonadal function, LH, FSH, and testosterone level. The 46XS and malignant structure are present. And then mostly probably it's due to defect in the synthesis by the congenital adrenal hyperplasia, and there is a 17 hydroprogesterone electrolyte renin or serum steroid for adrenal profile are traced. And there is a 45X and 46XX chromosome DSD. There is assess the gonadal function by the hormonal therapy. The history, what the history will know about the patient. The history patient with the DSD should include the following, like the parental exposure, prenatal exposure of the androgen by the progesterone, dinzol, or testosterone, or endocrine disruptor for the phenytoin or amniglutide. We know about this history of the patient, and the maternal virilization pregnancy mostly by the placental aromatase deficiency, which is aromatase mostly causing the conversion of the testosterone to estrogen, and also the leutomia is the mostly in pregnancy. Female benign tumor is present in the ovaries, which causes secretion of the androgen. And know about the family history of the female who have amenorrhea, and family history of the unexplained infant death. An examination. Mostly probably a palpable gonadal, which is a smooth round testes and globular differential texture is the ovary, and over testes is also the irregular structure higher up around the inguinal canal. Rarely globular swelling around the inguinal region may present with the prolapse fallopian tube. And external genitalia, the genitalia opening and the phallus size see less than 2.5 centimeters the macropenis and greater than 1 centimeter the clitoromegaly in female. This is the extent of the labiosacral fusion is assessed by the using by the Prader staging from where the staging 1 indicates the normally female development and the stage 5 is indicating the normally male appearance. Redundant staging is for the developing of the visualization of the CAH with the XY DSD and the external miscellaneous score is more appropriate for the XY DSD. And the external miscellaneous expression is the total is the 12 numbers and each number is giving the three numbers and one is the labiosacral sacrotal fusion and micropenis if the patient labiosacral fold is normally or not. That's why we give the numbers according to this. And there is also there is a hypospadiasis. How much higher hypospadiasis present, and there's a gonad. All of the maximum external muscularization score is present. And there is a Prader staging for a already labeled the XY DSD patient, and we see there is a one stage is the no relation normally female, but the five staging is the normal male appearance of the external genitalia. And then a miliary restriction can be identified by the using the rectal examination or pelvic ultrasound. Identification of the gonad and miliary restriction allow the preliminary classification of the DSD. And two things are easily available when you examine the patient have the gonads and we go forward the miliary structure if it's present or not. These are both are very important. Miliary structure is here without palpable gonad indicate the androgen excesses in a girl, while palpable gonad without miliary structure should raise the possibility of the androgen deficiency in a boy. The presence of the both gonad and miliary structure suggests that the gonadal dysgenesis or inefficient AMH action, and absent miliary structure and gonadal should be due to the abdominal gonad or testicular regression syndrome. This is the same slide as previously shown. If the patient have the gonad is absent and but the miliary structure is present, in the mostly patient have the tentative diagnosis in the mind there is XXDSD. If the gonad is absent and the miliary structure is also absent, mostly we suspect there is an NRK or the no testes or XYDSD. If the patient have the palpable gonad and absent miliary structure, mostly in the XYDSD, if the both of the present, if the gonad and the miliary structure means have the both tissue as avo and testicular DSD or AMH defects. This is as previously described the history of what you know about the history there and about the physical examination in which there is no ask about any hypospadias, early infant death or amenorrhea or infertility, or examine the inguinal canal for gonad and access the girth of the phallus and blind ending dimple at the phallus which mistakenly may be urethropnea or severe hypospadias, and also track their urinary flow track with also the midline raphe and give appearance of the stream from the end of the phallus and hypospadias, and go for the check the electrolytes, the cell vesting is rare before the second week of the life. Hormonal go for the androgen or androgen hormones can be misleading. Abdominal assay of the technique with the age appropriate reference ranges are required. Adrenal hormone best measured after the 48 hours. Imaging for the abnormal adrenal or appearance of the ultrasonography can indicate the CAH. Patient is present with what do you do for the initial assessment depend on the time of the presentation and likely diagnosis. First, initially we evaluate for the sex chromosome for the karyotyping, and then assess for the internal anatomy by the pelvic ultrasound for serum electrolytes and MRI. Abdomen pelvic may be required in older child, and measurement of the adrenal and gonadal steroid secretion, testosterone level, and gonadal biopsies may be considered. This is the diagnostic work of vary from XXDSD and XYDSD. It is a patient present with the congenital adrenal hyperplasia as already described. The 17 alpha hydroprogesterone is mostly present. Patient present there is a very high and a high level of the 21 hydroxylase, and there is Little higher. There is a beta SCD, and also all of the condition is a high of the 17 alpha progesterone. But DHES in most all of the also high, and there in the 21 hydroxyl 3 beta SCD and the 11 no. And these are all of the XXDSD, and another there's the XY mostly go for the androsterone, which is precursor, and converting into testosterone by the 3 beta HCD, in which see there's a low testosterone or low androsterone, and hydrotestosterone that varies as previously in the congenital hyperplasia of the pathways. Another, there is a high hydrosterone is high, and the low testosterone and low dihydrotestosterone, mostly deficiency by 17 beta HCD. And there is a high testosterone, high androsterone, but the low level of the dihydrotestosterone, mostly in the 5 alpha reductase deficiency. And all are the high condition, but there is a ambiguous genetic patient mostly present with androgen sensitivity syndrome. How to management of this patient is the management of DSD included in the first we diagnose about the life-threatening condition. What are the life-threatening condition and related to diagnosis and related to management of the 21 hydroxylase. And then there is a parental education for the psychological support of patient as well as parents. Decision about the gender awareing and initiation of the specific treatment and multidisciplinary team is required for the management of the DSD. In the pediatric endocrinologist or pediatric surgeon, geneticists or social worker is required. What are the immediate management is as early specially described. The serum electrolyte and blood glucose level should be monitored, and steroid replacement initiated in children with the congenital adrenal hyperplasia. And specific management, mostly steroid replacement is given in the congenital adrenal hyperplasia, and the testosterone in children with the biosynthetic defect, and topical dihydrotestosterone cream is required in 5 alpha reductase. Gonadectomy and estrogen replacement is indicated in the complete androgenicity syndrome. Here, the gender of the hearing is the big responsibility of to know about the what gender the patient is required, and what give the benefit in the future life. Decision regarding the gender orientation should be taken only after extensively evaluation and key consideration, including the sexual and reproductive prospects and feasibility of the reconstruction. Mostly children with XXDSD have prospect of the fertility should be reared as a female, and children with the simple realization from CAH often present at the later stage with the male gender identity and appearance. Male gender awareness with the hysterectomy and may be considered in this setting. If the patient have the most XYDSD, with the exception of the complete AS, where the female gender is desirable. And there is surgical management and class clitoroplasty for excess DSC is done before the 1 year of the age. Early vaginoplasty have the risk of the vaginal stenosis, mandatory surgery, and vaginoplasty therefore is required and done after the puberty with the regular dilatation and subsequently. Severely realized individual with excess DSD wanting the male gender if gender of identity should undergo for the hysterectomy and reflectomy and multi-step correction for the hypospadiasis and chorda is required in XYDSD. Prosthetic testis may be considered in boys with the anorexia. And how to consideration of when you do for the go for the gonadectomy is an important cause of the concern for the child with the gonadal dysgenesis, the risk of development of the gonadal neoplasm, and the XY dysgenesis with the abdominal testis. The risk is very low for the complete AS, and gonadal biopsy done after the puberty could be sufficient. And this table is show there is a when you go for the gonadectomy and when you go for the biopsy and when you do for the monitoring. If there is a patient have the XYDSC, the gonad location mostly in the abdomen, and malignancy risk is very high because of Y chromosome. Patient mostly go for the gonadectomy. If there is XYDSD and gonad is present in the scrotal, but the malignant risk is variable from 2 to 10%. Then go for the biopsy. If biopsy is negative, then no need of the gonadectomy. And the complete AS and gonad is present in the inguinal canal, and the malignancy risk is very low and required for the biopsy. If negative, no need for the gonadectomy. And here is the WT1 gene, which is present with the renal involvement. Let's say there's a gonad location, any gonad location is present, but the malignancy is high. When you diagnose the WT1 gene involvement, then early as much as possible, the gonadectomy needed. And 17 beta BSCD and ovotesticular is varying from the gonadectomy. Thank you.